Okay, so while a lot of potential ethical issues could come up in integrated care, the main buckets that those would fall into typically are informed consent, privacy and confidentiality, documentation, and multiple relationships. The multiple relationships, I think, are kind of less common, but I was able to find an interesting little case example of something that could happen, particularly in a smaller integrated practice. So informed consent. In general, for informed consent to be considered valid, patients should never feel pressured to agree to any kind of treatments. They should fully understand what the treatment is that they're signing up for and what all of that entails. They should understand what the costs are going to be. In an integrated care practice, that could be kind of confusing because if it's for example, a counselor who's working from an agency, but they're embedded within a primary care practice, they might be part of the primary care practice for billing, but they also might be the outside entity for billing. And so patients being, in that midst of that warm handoff, yes, their likelihood of connecting with mental health services is higher, but they might not realize that it involves being opened up with a whole new agency so that that agency can bill. So some of those, any kind of payment issues, I think, can be confusing and could get lost in the shuffle, just trying to make sure that we're doing good integrated care. So part of informed consent for us is making sure that we do address those issues. Patients should also fully understand what it is that they're getting involved with. So again, if somebody's in a mental health or in a primary care practice and is getting connected with a mental health treatment provider on site, do they realize that this is, being a referral for counseling? How long will that counseling entail? What does counseling entail, and how is that different from when they see their primary care physician? To being able to give a full description of what it is that you're referring, and then after maybe that first visit with a mental health professional, that mental health professional being able to explain what it is that they're recommending and how that does or doesn't differ from their typical treatment at that practice. Also, for them to understand, patients need to understand what kinds of information, and this does tie with confidentiality and privacy, so we'll talk about that a little bit more, but they have to have an understanding and be able to give consent as to what information they know will be shared back and forth between treatment providers. It is important that they have an awareness of what the rules are around that and what the regulations are, both at the state and federal law level, but also within particular practices. Treating minors. So this can be a little bit of a tricky thing because on one hand, we know that involving parents and family members and guardians in the treatment for mental health, any treatment for minors is absolutely critical. But in Ohio, mental health professionals can actually do up to 6 sessions or 30 days of mental health treatment with a minor that is 14 years or older without having any kind of consent or knowledge of the parents. At that 30-day window or 6 sessions, whichever is shorter, they either have to discontinue treatment or they have to contact the parents and get the parents' permission and consent to treat their child. If they do get the consent from the parents, those parents cannot be financially held liable for any of those sessions that occurred prior to consent, which again makes it kind of this weird gray area for a lot of practitioners. Is that we all know how businesses go. Our bosses and the CFOs want us to be able to bill for everything, but there's going to be this little window of time where you might need to start working with a minor and not be able to recoup some of the cost from that or be able to bill the parents' insurance until after the consent has been received. And of course, the person has to be able to understand and has the capability to consent for treatment. So anybody who's in the midst of a psychotic episode or is under the influence of drugs or alcohol at the moment or has a developmental or intellectual disability, you have to really truly be able to say that they are competent to provide consent. So privacy and confidentiality. So HIPAA and 42 CFR Part 2 are those federal laws that guide privacy and confidentiality. Now, it gets kind of tricky because the law in Ohio actually changed back in 2009 where prior to that, mental health treatment records were treated very differently than all of other health records. So for a very long time, mental health providers would definitely always have to have a signed confidentiality statement authorizing them to release any information to the primary care physician. Now, under HIPAA, we know that primary care has been able to communicate for shared patients or referral of patients to other specialties pretty seamlessly, but mental health had been the exception. But in 2009, Ohio changed their laws to be reflective of the federal level. So now we can seamlessly share information back and forth, with one exception of progress notes and psychotherapy notes, which we'll talk about in more depth in a second. But many parts of the state have not caught up to that law being what it is. So that is the state law, but many, many agencies still prohibit sharing information about a shared patient without a confidentiality agreement signed. That is their policy, and technically they are allowed to hold to that policy despite the fact that the federal law and the state laws are looser. With 42 CFR, that is essentially the HIPAA for all substance abuse treatment provisions under certain classifications. And it could take a full day to fully explain what 42 CFR Part 2 is and all of the nuances of it, and we're certainly not going to do that today. But it's something worth noting that if an organization or entity is covered by 42 CFR because they provide substance abuse treatment and receive federal dollars, that even if you are the primary care physician and receive information, documentation from that organization or that provider, you now have to treat those records as if you are a 42 CFR provider, which means you have to have extra protections around those records. So it does make things very complicated. And the regulations don't allow for that provider-to-provider interaction and information exchange without there being some type of signed agreement from the patients allowing that to happen. Or with standard mental health records, you can fully exchange information. And important to note, with or without the client's permission. So a patient can tell their primary care physician, I don't want you talking to my counselor, or vice versa. But if there is a need to know, you're certainly allowed to do so, even though the patient has already said not to. That's where it becomes kind of an ethical conundrum: is do I do this or do I not do this because the patient has said I don't want you guys to talk, but maybe you know that you really need to. So we will talk a little bit about that, and I want to hear all of your thoughts about it a little bit sooner, or a little bit later. Documentation, excuse me. Documentation is where this gets really funny, because in many organizations that have an electronic health record and they have all services within that system, so the larger hospital systems, there might be the ability to see notes from the psychiatric provider, from the counselor, to any specialist that they go to, also in primary care. And all of those notes may be visible and able to be exchanged among providers, which is ideal because then you guys can all actually know exactly what's going on with your patient that's shared. In some organizations, you actually have to what's called break the glass in order to see any of the mental health notes. And there's an interesting amount of literature around how patients feel about breaking the glass and how providers feel about breaking the glass and whether or not they need to. I know that it's a major frustration for some of the integrated care partners we've worked with because they feel as though they should be able to access this information, but their own legal department says they're not allowed to. Where I tend to land with this is we need to understand the difference between progress notes and psychotherapy notes, because psychotherapy notes are the only thing that is distinctly held separately as a confidential document within traditional mental health treatment. So progress notes are everything that you have to document in order to get payment from an insurance company or Medicare, Medicaid. It's the day, the time, some basics around what was covered, are you working towards the treatment plan, what is the progress towards the treatment plan. But it's not so much like the process of what's going on in the individual. It's not what we think of in terms of process types of notes. So psychotherapy notes are those notes that you might keep that contains the detailed history of somebody's trauma timeline. So when I worked with somebody who was a survivor of trauma, early in the sessions, try to figure out what happened to them in a longitudinal fashion. And I would want to keep some kind of notes of that to make sure that I didn't have to constantly re-ask about, well, who was the third person that offended against you? I don't want to re-traumatize people. But I also don't want to put that kind of detail into my progress notes, because progress notes are also something that can be accessed during an audit, can be accessed by insurance companies, and in mental health treatment systems can be accessed by the local county board if that agency receives any board funding. So it's really a lot of very sensitive details that I wouldn't want to necessarily put in there. I've heard of kind of horror stories of people putting information about a patient's sexual trauma in an electronic record, and then having, say, the podiatrist who's on that team break the glass to read that record and now is asking the patient about when they were raped. That's very inappropriate. So what you put into psychotherapy notes would be kind of that stuff that you want to keep, but you don't want everybody to have access to. And we have to be mindful about what we put into progress notes then, because if they are accessible by everyone, is this something that everyone really needs to know in order to be able to treat the patient? Or is this something that only some people really need to know in order to treat the patient? And that can be a really fuzzy area. So a couple case illustrations. One, so let's say and this is where the multiple relationships come into play. I hadn't thought about this, but I think if we're working in a smaller practice, this is something that you very well could see. So there's a social worker working in an integrated health setting who's been providing counseling to a nurse practitioner at the center who's struggling with debilitating anxiety. About a month before the counseling began, the social worker had been treated by the nurse for a chronic urinary tract infection. As part of the treatment team, or part of the treatment, the nurse practitioner conducted a pelvic exam. Now, obviously, this shifts the power, shifts the professional relationship from what it was, because that's a very intimate kind of an exam. So, how do they handle that going forward? Because if you're working in a small setting, you might need each other for those services, but then you're still kind of colleagues at the same time. So it really puts us in a bind of making sure that there's lines between our relationships and that there doesn't feel to be a power differential in any of those relationships, because then you would need to ethically refer to someone else. So here's another case illustration: informed consent and confidentiality for behavioral health services. Let's say Dante is a 6-year-old African-American male presenting to his pediatrician for a well-child visit and has expressed concerns related to anxiety. He's there with his maternal aunt because his mother was unable to attend the appointment. And the pediatrician consults with an integrated care team member for a warm handoff. But now can you see, can that integrated care team member, can the behavioral health person see Dante? Because he's not there with his mom, he's there with his aunt. So does anybody have thoughts on this? Should the counselor see, and just unmute yourselves and jump in if you have any thoughts. Go ahead, Sarah.
I feel like, yes, based on what you were saying about how you have a certain window before you can sign it.
Okay. I mean, yes, technically.
This is Tessa. I know I jumped in late. So I don't know if it's right or wrong, but I can tell you what we do in our office, because this comes up pretty frequently. The patients check in and they sign kind of like a blanket consent to treatment. And so because the PCP is saying, hey, as part of this treatment, I want you to talk to this person, we feel as if that covers us in this clinic.
That's great. And I think in your clinic, that probably makes a lot of sense. I guess in some clinics, this might be tricky if it was like an outside organization having their counselor on site, because you're right, you can do treatment. Sarah's right, you can do treatment with somebody for up to 6 sessions or 30 days, but that's only if they're 14 years or older. So for a 6-year-old, it would be a trickier scenario. In Tessa's workplace, that would work, but not in all. So we have to be mindful of, exactly what the policies and procedures are, because it's going to vary a bit. And then here's a case illustration of Sienna, a 16-year-old African-American female presenting for well child visit, and presents with some concerns related to skin picking and anxiety. She's interested in behavioral therapy, but doesn't want her mom to know about it because she's concerned that the mother might be upset or feel responsible for the behavioral concerns. Thoughts around this one? Amy?
I guess I would try to have a conversation with her and kind of probe a little bit deeper as to what her concerns are regarding her mother, in an attempt to bring her mother into the picture. I'm not sure that I would jump over and say, oh yeah, you're over 14 and you can see this person without your mother's consent. I'd make an attempt to try and bring the mother in and make Sienna feel comfortable with having her mother share in what's going on.
I love that.
Yeah, and I would also, I would concur with that, and I would be concerned about insurance. And, if it's one thing if someone goes to a public mental health facility without using their insurance, but if they're seeing their primary care and it's going through their insurance, their parent's going to probably get an EOB.
Yes, they are. Yeah, particularly in that scenario, it's not like it's being very well hidden. So when you look at the law on it, the law would say you could do 6 counseling sessions or up to 30 days of counseling sessions. At no point could medication be started. So if that started to look like something that needed to be added, that would absolutely have to involve the mother. But I really agree with both of you that your best practice is going to be to try to get Sienna to feel comfortable bringing her mom in. And that might mean taking one conversation before you tell the mom, but I think it would be a very good idea to continue to try to make her feel more comfortable with that, because maybe that'll actually help to relieve some of the anxiety in addition. So I pulled from 3 major sources, and we can share those with you, or those are, the citations. Bless you.
Thank you.
Other kinds of ethical issues might come up or concerns. What kinds of things do you guys